Okay, hi, my name is Ariane Huggins, and this is my TED Talk for SIADH, which is Syndrome of Inappropriate Antidiuretic Hormone. It's a mouthful. But how I understand this is going backwards, so understanding what a diuretic is. So a diuretic goes and tells our kidneys, like, hey, we have way too much fluid volume, let's excrete it through the urine. An antidiuretic hormone, which is ADH, it's released from the posterior pituitary gland. It goes down to the kidneys and it does the opposite. So it tells the kidneys, like, hey, we don't have enough fluid volume. Let's go ahead and hold on to this fluid and not excrete it through the urine. So usually this creates homeostasis in our body to have correct osmolality. However, when we have SIADH, the posterior pituitary, it was releasing this ADH, and it's causing fluid retention because these people may not even have a low volume of fluid. They may have a regular volume of fluid, and then they're secreting all this ADH, so it causes that water retention. Water retention then causes dilution of salt, so then the patient gets hyponatremic, and this can cause all sorts of problems. So depending on what causes the SIADH, it can be self-limiting or it can be chronic. So let's go ahead and jump into what can cause this. Cancers can definitely cause SIADH. The most common one would be small cell lung cancer, but lymph node cancers, prostate cancer, pancreatic, thymus, those can all also cause ADH. Why? Usually it's because of anti-cancer drugs, palliative care drugs, or even chemotherapy can raise ADH in the body. But tumors can actually produce ADH as well. So you're getting ADH from two places in the body. Then we also have other medications like chlorpropamide. It's a diabetic medication. It can cause SIADH because it appears to create impaired water excretion due to the increase of renal vasopressin. Carbamazepine, opioids, oxytocin, antidepressants like SSRI can also increase ADH. Something else is like surgery, and we're not too sure why it causes ADH to increase, but it does. And then general anesthesia. So as nurses, we want to make sure after a patient comes back from surgery, we're looking out for signs and symptoms of SIADH. And then central nervous system disorders can actually cause SIADH, so like Guillain-Barré syndrome, head trauma, head infection, stroke, systemic lupus. These can all cause ADH because electrolyte imbalances with these type of diseases. And then, of course, adrenal insufficiency, COPD, hypothyroidism, and any patients on positive pressure and mechanical ventilation are actually at risk of SIADH as well. So let's go into those clinical manifestations. What happens to our patient when they have SIADH? Well, I'm a very visual person. So in my brain, I had to draw out. Here's my pretty picture of what happens to a patient when they have SIADH. So we have to go back to the pathophysiology when thinking about these things. So they're going to be extremely thirsty because they have a depletion of salt. Their body's thinking they're dehydrated. They want water. They're also going to have weight gain. Our weight fluctuates daily, 5 pounds usually of water weight. But when we're retaining a whole bunch of water, that weight's going to go up. So we want to always weigh the patient at the same time, wearing the same thing with the same scale to get an accurate reading and make sure that either their weight's going up or it's going down with treatment. So what else can happen? These patients can have increased blood pressure, increased heart rate, and this is going to cause a pounding or a bounding pulse. This is because, again, pathophysiology, we have so much water in the body, it's getting into our blood vessels, it's causing the blood pressure to go up, the heart rate to have to pump harder to get all this volume through, which causes the pulse to be bounding. Also, we're going to have decreased urine, and it's going to be super concentrated. Again, that ADH is telling the kidneys, hold on to this water. The kidneys are only secreting a little bit of urine, and it's going to be super concentrated because we're holding on to all that excess water that would normally dilute the urine. Then the patient can also experience nausea, vomiting, loss of appetite, and also decreased deep tendon reflexes. This is because hyponatremia, it's low sodium. Sodium is important because we need it for muscle contraction. The GI is a muscle. Deep tendon reflexes need the muscle. So anytime that a patient has this, their GI is going to slow down because it can't contract and digest food. They're going to experience all of these symptoms of nausea and vomiting. They can be hypothermic because of the fact that they have so much water in the body, and it's hard for the water to maintain our temperature because of that. And then they're also going to have neurological changes because all this fluid volume has to go somewhere. It can eventually reach the spinal cord fluid, which then can go into the brain and cause all this swelling. So they can have level of consciousness changes, headaches, seizures, lethargy, coma. So it's just not good, and these are signs to look out for as nurses. So what type of medications can we give these patients? Obviously diuretics, so we're going to give them diuretics so that their kidneys start producing urine. We can give them demoxicillin, which is going to tell the ADH to stop. It's going to tell the kidneys to stop responding to that ADH. And then we can also give them vasopressin receptor antagonist, which is going to just stop the production of ADH. IV fluids can also be used, ordered, like hypertonic or isotonic. We really want to watch out for this because of fluid overload with these patients, but they also may have electrolyte imbalances. They may need these. And because of we're giving diuretics, they may also lose potassium, calcium, and magnesium, which will cause more electrolyte imbalances. So supplements for these may be ordered. As a nurse, what do we do for these patients? Well, we're always going to assess their baseline so that we can assess if they're getting increased intracranial pressure or if they're going into seizures or if they're getting better, hopefully. But we always want to get that baseline. We want to listen to their heart and lung sounds. This is because all that fluid, we don't want it to go into their lungs and cause pulmonary edema. We want to make sure that their heart is pumping correctly with all these electrolyte imbalances. Obviously, we want to monitor labs, especially sodium, but all the other electrolytes as well. Again, doing daily weight checks. We want to position the bed no more than 10 degrees. This enhances the venous return to the heart and increases left atrial filling pressure, which then thus reduces the release of ADH. We're going to administer any medications and evaluate the treatment, making sure that it's working. We're going to monitor their I's and O's. They're going to be on a fluid restriction, so we want to make sure we're monitoring that. With that, we want to do oral care because they're going to be so thirsty and we're going to want to wet their mouth. And with that, we're also going to want to distract them because being thirsty can drive you insane. And then patient education, we want to make sure that they understand the syndrome, the pathophysiology, why they have it, the prognosis, and the plan of care so that they can get better and hopefully prevent this from happening again. So what are complications? We've talked about a lot of them that can happen in different systems. Usually it's neurological because of the hyponatremia, so headaches, memory loss, depression, level of consciousness changes, hallucinations, tremors, seizures, rhabdomyolysis. All of these things can occur. It can also go into musculoskeletal because of muscle cramps and things like that. Respiratory because we can get respiratory arrest and death. And then cardiac because the heart is pumping so hard. So this is a multi-system type of thing that's happening in the body when we have SIADH. So we really want to look out for all these signs and symptoms as nurses to make sure that none of these complications happen. So that is my TED Talk. Thank you so much for joining us.